necessarily the obvious push for it, and all of a sudden a global pandemic kind of pushed us in that direction. And so our practice kind of led the way, I think, in our system at least. But now I get a call probably daily now of, hey, we need to do this somewhere else in the city. And it's obvious that this is something that's going to be on the forefront of everyone's mind. And that's why you've got this fantastic panel that we're going to get to talk to from a lot of different angles in ways that I think most of us would have never imagined even a couple of years ago we'd be talking about. Whether it's high-end technology, whether it's devices, whether it's going back to basic medicine in terms of what we all learned in medical school. There's a lot of different angles to kind of talk about. So, all righty. So first person I'd like to introduce to all of y'all is Dr. Patrick Muck. So Dr. Patrick Muck is the Chief of Vascular Surgery at Good Sam in Cincinnati. And what he brought to the table for us really was a focus in on some of the technological things that are really different that most of us aren't aware of, that are really being developed in and around this space. We hear about the pathology because we saw it in medical school, or we talked about it on the wards, but now it's how does technology really play into this? And so his article in the journal was New Diagnostic Tools for PE Detection. And so it talks all about the platforms. And so, Dr. Muck, welcome. We really appreciate you being here.
Hey, Tom and Alan, thanks so much for having me. This is quite an honor to be part of this journal and this edition. So thanks so much.
Of course. We really appreciate you being here. One of the big things that struck me is it's very obvious when you read your article and you look at these pieces of software that this is something that's going to come down the pipeline, because we see it in our handheld devices these days that once you have this type of technology in your hand, it's going to spread like wildfire. And the question that I wanted to really get to with you is, it's obvious to the clinicians that have this in their hand, but how do we talk to partners in the hospital system and demonstrate value from this? Because this is a question, none of this is free. This is always going to be there's going to be people that we have to work with in our healthcare systems to justify the value of these things. So how do we demonstrate that value? How do we broach those conversations?
Yeah, great question, Tom. And just like you said, that's exactly what I have in my hand here. You know, in our institution, I have a lot in common with you. I'm super lucky. I've got 5 incredible partners. We've got integrated residents. We've got fellows. Good Sam's been around for 175 years taking care of patients. And it's really kind of a big little hospital, so to speak, because we all get along, whether from the intensivist to the IC to the IR to the pulmonologist, et cetera. And really credit is due to our pulmonologist, Dr. Chris Hayner, who early on identified the value of AI and how it really provides rapid communication, because you can rapidly, like you alluded to, in the palm of your hand, in no time review a CTA, whether or not there's a central or a peripheral embolus or an embolus at all. You get an RV-LV ratio. And then from there, you can really risk stratify and provide rapid communication and rapid care for these patients. So for us, it was easy. Chris led the way. We already had AI, which so many systems have with the stroke team. And for us, it was Viz AI. And I can't say enough about Viz AI and their team. They are all clinically based before they join this, so they get the big picture. And it was really an easy sell that Chris did to the system, showing that, you know, that we can all communicate so rapidly. Not only can you review the imaging, but you can risk stratify and communicate so quickly through HIPAA compliant text messages on our app. And so it was an easy sell. And you know, with that, as we showed in our article, again, being lucky, our trainees are incredible, and Jake Shapiro deserves so much credit for his retrospective study that showed that with AI that started in 2022 and went to 2024, we in fact were able to decrease mortality mainly by quick risk stratification and quick anticoagulation.
It's really exciting to hear you talking about this, and I'm just looking at our panel and everyone's nodding along, because this is so obvious to those of us that work in this space that if you leverage these things and you hit these points, like you said, about the rapid triage and identification and risk stratification, the quality of care goes up dramatically. And I think that this has been very obvious in other areas, like the standardization of STEMI care, standardization of stroke care. And you mentioned a lot of parallels to stroke care. Do you see that coming for us in the future as far far as that kind of centralized pathway that you see in stroke. And kind of the addendum to that is also the concept of telestroke is really taking the nation by storm. So is that something we're going to see for tele-PE care down the line?
I don't think there's any question. There's, you can be over in London, you can be in Australia. Alan is such a believer in imaging, and then you combine imaging with AI. You can literally provide expert, an expert opinion from anywhere in the world. And so I see this really becoming, like you said, it's going to be standard of care, and you can get an expert opinion no matter what continent you're on, because so rapidly you can look at these high resolution images and provide an opinion. Not only that, on the app you can get automatic RV to LV ratio, the troponin, HNP, or BNP, etc., is all uploaded. And so really you can, sometimes for our patients, even before they get back from the CAT scanner to the ER, we've all communicated and we know whether or not we're going to intervene or admit to the unit or to the floor on AC and continue observation from there. But no doubt this is going to be something that you can really communicate anywhere in the world and provide your opinion.
So you're bringing up lots of questions and stimulating. I'm sure the panel has got questions of their own. So let's go ahead and introduce the panel first so they can jump in and ask questions of us and one another.
Absolutely. You have all met Dr. Muck now. I'd also like to introduce you to Pavan Thengudu. Dr. Thengudu is a critical care intensivist up in the Woodlands, where I practice. He works for the enemy, unfortunately, over at Herman next door. But you can tell this is something that we are all on the same page for, and he and I collaborate regularly despite being at different institutions entirely, because this is something that we really care about as a community as a whole. You also have Dr. Joe Nome also joining us, one of our other partners from Methodist Clear Lake, down on the southeast side of Houston. Dr. Nome is one of our vascular surgeons here in the Houston Methodist group. We also have Nicholas Mawad coming to us from the McLaurin Medical Group up in Bay City, Michigan. He's a vascular surgeon there and the chief of vascular surgery there. We will have Paul Haddad joining us. He is one of our graduating residents from the integrated program. Unfortunately, he has some clinical duties he is finishing up, and then he will be joining us. And then last but certainly not least, Dr. Steinberg, one of the cardiologists and chief of cardiology at University of Washington, is also joining us virtually. So that's our crew tonight.
That's the crew. So let me ask you a question. Actually, it's great that Dr. Steinberg's on. So I think cardiology has done so much of a better job than we have in defining, STEMI. Here's the STEMI protocol, and nationalizing what these standards should be in terms of door to balloon time. And stroke has done the same thing. Well, you come in here with an ischemic leg. It's like, okay, well, we'll get you in an operating room at some point in time. Ischemic bowel, well, we'll next room available. And so PE is kind of the same. There's really not a benchmark in terms of the speed with which we should move the patient through the organization. So, Dr. Steinberg, I really like your thoughts on the standardization of care and how you guys actually managed to pull it off.
You mean in terms of STEMI?
STEMI, yeah. And if you told me 10 years ago, door to balloon time at Methodist in 90 minutes, I'd say, you're dreaming. Can't happen. It's never going to happen in our system. And yet, it happens every day now. So it's like Thomas said, about building the systems and creating national standards that force us to comply with it.
Well, I think one thing that's helped with door-to-balloon time and establishing STEMI programs is pretty solid data showing at what point, if you intervene on, you have worse outcomes. So we really had a very defined period and to work within. How to build that out is really a combination of having a core group in a hospital, like a cath lab team that knows their job, knows when to respond, and is located within a certain radius of the hospital, but also, and something that people long before I ever even entered medicine in the state of Washington and really the city of Seattle were headwaying, is organizing a group of EMTs and a multi-hospital institution, or rather a consortium, we call it Medic One, where when a patient comes in with a certain clinical need, for example, a STEMI, they can look to the closest hospital and they're in touch almost immediately to figure out staffing, whether or not there's availability. And so there is a communication network that's occurring even before patients hit the hospital in many of these situations. And that has really made a difference, I think, for STEMI care overall.
No, and that really leads into Dr. Thangutu's article about massive pulmonary embolism. One of the big things that he and I bonded over when we first met really was, how do you define these things? And he's a savant when it comes to the literature and the history of all of this. And that was one of the things that struck me and really made me want to make sure that Dr. Thangutu was involved in this. And so one of the big questions that I have asked him several times, because I always want more and more detail on how are we going to do exactly what Dr. Steinberg was talking about, how of defining things and then coming to those conclusions of how are we going to measure and then how are we going to then put this into practice, is we currently use terms like massive and submassive, which confuse things sometimes because they confer different definitions depending on who you're talking to, whether it's a pulmonary embolism specialist or a layperson or another clinician. So the question for you, Pavan, is really, are these the right terms? And if they aren't the right terms, what should we be using? Or should we be using a different schema when we have these conversations in how to define them before? Because I think defining these terms is probably the most important thing before we start trying to generate the right data.
Yeah, I think that's a great question, and one I've been thinking about for years. So I'll say this. When I first started treating pulmonary embolism, I thought the guideline definitions were correct. That's what I used to triage. But as I started to apply those definitions at the bedside, my patients weren't benefiting from those definitions. They were getting sicker. I was missing the windows for intervention. Our patients with massive pulmonary embolism were dying. And I started to get really confused. And then when the Bangalore data came out showing that 34% of these patients are sicker than we think, they have, with intermediate risk PE, are in cardiogenic shock. How do we decide what is right? And what I started to realize was that the terms are right. Submassive, simple, massive, they're simple definitions by the AHA that really help us. But the definitions of how we diagnose them and how we triage them, I think, are lacking. They're not benefiting patients or bedside teams. And I think that really speaks to how successful PERT teams have been as they've come together to see these patients, follow them from admission, sometimes even in the field, to where they go into the regional PERT centers to get to where they are. So my answer would be, I think the guideline definitions are wrong, the terms are correct, and what we have to do as a community is figure out how to better triage a massive from a submassive. And then the schema really comes from, yes, Dr. Steinberg said it great, we need more data. And we need to really dive into what this looks like. And I'm really pleased to see some of the registry trials that are coming out that are looking at this. And we're starting to see large population data that's diving into what's been going on and how we've been doing, and is there opportunity for better.
It's always interesting to hear these conversations because there's such a striking difference, especially in the city of Houston, because we have such a large medical center and then we have the community, and we often treat these as kind of two separate areas, and the mentality is quite different. And you and I work in a community that's 40 miles outside of city center, and you end up having a lot of people say, I don't need more data. I see this in front of me and I'm ready to go. But then if you go to an academic meeting or you go to the more academic centers, you absolutely need, in order to move the needle, that robust set of data to really change how the guidelines are and then how certain groups are going to practice. So that really leads me to kind of the next question for you. If you had kind of ultimate authority within the societies or a government entity to say, we're going to invest our time, energy, resources into either clinical trials, whether they're randomized or registries, or is it how we're going to study these patients in terms of how long, where do we get the best bang for our buck? What is the thing that moves the needle, not necessarily in terms of the clinical science, but in terms of changing how we practice day to day?
I don't even look at medicine for this. I look at the origins of CPR and how we started proliferating CPR in the country. It was a mayor in Pittsburgh who collapsed in the middle of a speech and died. And a nurse in the field who happened to work with Dr. Safar at UPMC knew that CPR needed to be prescribed. But what they used to do at that time was a hearse would show up, no ambulance, a hearse would show up and transport the patients. The hearse had a fiduciary responsibility to the funeral home. And so they would slow roll to the hospital. This nurse hopped in the back of the car, did CPR en route while they were driving, couldn't get anything done, did the best she could, showed up to Safford's Hospital, and they kept him alive for an additional 8 days. But this mayor's death catapulted the propellant of CPR on a national stage, that we need to incorporate this good, effective CPR. So sometimes who you are matters. And so I think, we know the tools. And the question that I always ask is, do patients with massive pulmonary embolism need to die? We have the opportunity to save a lot of these patients. We know from the literature only 30% of them are getting lytics, that there's an underutilization of that in the setting of massive. We know that early VA ECMO can help these patients to protect them, just like protected PCI and cardiogenic shock. If you look at the Maryland data, we're seeing 96% survival at 1 year. So from an ethical perspective, the American Thoracic Society, there was an editorial where they asked, before we can standardize VA ECMO as first-line therapy for massive PE, we need to triage these patients to centers of excellence. That was a statement they said at their national meeting in 2018. And they were already having that conversation of regional PERT centers, regional ECMO centers. So yes, I absolutely believe randomized control trials are necessary. They will swing the majority of providers into understanding what helps patients. And we also want to see that data too, right? But then on a governmental level and a societal level, if you were giving me full control, I would say, which subset of the disease are we going to study right now? The massive data, I think we understand pretty robustly that we have opportunities to intervene on them rapidly and help them quickly. But this intermediate subset of the patients who are not in shock, the same way, like an unstable angiogen comes in and we'll work them up and stabilize them. What do we do in those settings and how do we do it? We need to understand that process a little better and a little more safely. And I've been really impressed with what you've been doing in the Woodlands. You've been able to get some of your patients who have this simple PE or the intermediate risk home within 24 hours. And not many places in the country are doing that yet. A lot of us are still on average, if you look pre-PERT era, average length of stay is 4 to 9 days for a patient with a PE. Since PERT centers have become involved, it's been going down to 2 to 4 days. And some places are going even more rapid for de-escalate or discharge home. So I think there's a lot more work to be done on the low risk side and the intermediate risk side to figure out how we get these patients to a national standardized level of care similar to STEMI or chest pain.
And it's funny that we talk about massive pulmonary emboli as much as we do, considering it's such a small fraction of the volume of patients that come into our ERs with pulmonary emboli. But the thing that's going to move the needle, like you said, is that data. And something that has tremendous amount of data, but we somewhat kind of fail in a lot of different aspects for a lot of different reasons, is anticoagulation, all right? And it's something that it could be from not adequately anticoagulate as someone comes in the door in the hospital. It can be discharge planning that doesn't allow for that patient to get on the right anticoagulant that they can actually be on, coming off too soon, staying on forever when they probably shouldn't. And I don't see Dr. Noam on right now, so I was going to direct my questions at him from the anticoagulation standpoint. But for interventionalists, Dr. Mawad, you're a vascular surgeon in the community. You take care of patients in the hospital, and then you see these patients presumably in your clinic, or you have a system in place. Is there a role for the interventionalist to be intimately involved in this? Do we need to have a more robust, because we know these gaps exist. The number of times we see patients come in the ER and they have a new PE, a large PE, and say, yeah, I had one of those 6 months ago, and I haven't been on blood thinners for 5 months. And you go, well, that doesn't really compute for what I know from guidelines. Do we need to be more involved? Do we need specialized care? How do you guys do it in your practice? And how would you imagine kind of our optimal pathway for this?
Yeah, fantastic. Thanks, Tom. I think a gestalt is we should definitely be involved. I think it's a little bit different for vascular surgeons used to being a little bit more technical when you're involved in intervention, but really these patients require a holistic approach. And sometimes the anticoagulation, making sure they remain compliant or giving them the appropriate dose at the appropriate time is just as beneficial as consideration for intervention. I think we all agree that none of us want to do an intervention unless it's absolutely necessary. And particularly once you do one and it's successful, you want to avoid having a recurrence that could easily be avoided with appropriate anticoagulation. So we tend to be very aggressive about it up front. In addition, for those that are considering starting a PERT program, particularly in the community, if you don't have all the robust resources for some of the larger health systems, I think you absolutely need to be involved because you're developing a program per se. You're going to talk to the ER, talk to your colleagues, pulmonary, critical care. And as an interventionalist, I think it's important to keep that in mind because it's just as important as the intervention, as making sure that they remain appropriate or compliant with their medical management. So we're very, very involved with that. We actually have a dedicated anticoagulation clinic. We're part of that. So for non-PE cases, let's say other situations where there is a VTE episode, we're available for a referral or for a consultation, which I think is important, and I think it should be an integral part of those that are receiving just medical management.
So it seems like sometimes a silly question, but do you guys still use Coumadin, or is this something, does that expertise still exist? I find that if we tell people to go see their primary care doctor, if that primary care doctor is under the age of 50, they probably never dosed Coumadin in practice, just because of the proliferation of NOACs. Do you guys have that expertise in your community?
Well, so yes, and I'm not gonna pretend that I like getting the Coumadin calls about doing the INRs, but we definitely have that as an option, and I'm going to touch on that real quick. But Tom, you said NOACs. We don't call them NOACs, and I'll tell you why. We learned the hard way. We call them DOACs, direct oral anticoagulants, because in some places that don't have computerized or EHRs or EMRs, it gets written in a paper chart, and so it's written NOACs, and the patient comes the next day with another episode because they thought it was no AC, no anticoagulation, so it was discontinued.
Wow.
So we're very particular about not calling them NOACs, we call them DOAC. Yeah. So sorry for that. So I'm very, very particular about that. But I think, once you get really involved in a lot of more complex patients, combined DVT, PEs, clot in transit, et cetera, I think we see more patients with, either hypercoagulable state or some abnormalities with their coagulation cascade. So we tend to revert to Coumadin or warfarin as the gold standard. But for the most part, if we can get them on a DOAC, we absolutely do that. We have our social workers and our teams, our anticoagulation clinic, price check them just to make sure, because we of course want them to be compliant. We don't want finances to be a problem, and if unfortunately there's an issue with that, then we revert back to warfarin, because the most important thing is that they're anticoagulated and that they're compliant with their anticoagulation regimen.
Hey Tom, on the front end, real quick, on the front end, that's the advantage of AI. Every hour that somebody with a PE is not anticoagulated, their mortality goes up. And so again, that's another plug for AI, in that you can communicate so rapidly and institute your anticoagulation quickly. And at the end of the day, like you said in the beginning, we still have 10, 15 years, and like Maven was saying, so much to learn from this. We don't know, is it time is right heart? Is it time is lung tissue? Is it time is anticoagulation? Is time ECMO? We have a lot to learn. There's a lot of similarities with the stroke team, but then again, there's not, because it's not always time is brain like it is for those folks. And that's again, I just think an advantage of AI though is early anticoagulation. So perhaps time is anticoagulation for this patient population.
So Nick, $500 a month. I mean, I had this conversation with a patient this week, and she said, basically, I can't afford it. I can't do this. No. And actually, Janssen, so you go on their website, you can apply to get a token, which is really a number that they send to your pharmacy, and it goes from $500 a month to $10 a month. Yep. And so it's remarkable, but most people don't know about that. And you worry about compliance. I worry about compliance. It costs $500 a month also.
But that's where I like Dr. Mawad's thing about having an anticoagulation clinic, right? Having that expertise to be able to coach patients. Because this isn't about the clinical medicine. This is about how do we actually get these medications to the right people? And you just have to know what number to call, what website to look at. And your average interventionalist is probably not going to have all that expertise locked up in their brain. But if you have a dedicated resource in your hospital system, you'll probably be able to find them. So really quickly, I want to introduce our last member of our group that was able to join us. This is Dr. Haddad. He is one of our graduating integrated residents here at Houston Methodist. He'll be joining practice up in the Dallas area in not too terribly long. For some reason, time keeps moving forward. Yeah.
Thanks for having me.
Yeah. All righty. So, shifting gears a little bit to the interventional side, and getting away from kind of the guidelines and data. Wanted to talk really quickly about how do we were just before getting on the air talking about the proliferation of different devices, number that are in trial right now, the number that are available, that most interventionalists are hearing about left, right, and center. And while this used to be something where you had one, maybe two players in the market, we're going to have probably 10 different options and not too short of an order. And so for the interventionalists on the call, and I'm going to start with Dr. Mawad, and I'm going to jump quickly to Dr. Noam. How do you pick what you're doing right now, and how are you going to evaluate the devices that are coming down the pathway? What are the key things that a budding interventionalist should be looking for? What should people be looking for in this space?
Yeah, great question. And the crowd, the field is very crowded. I mean, and it just gets even more crowded, honestly, by the week. I think we realize, at least anecdotally, that there is an excellent opportunity here. Patients, anecdotally, have excellent results when we treat them, but which lends an opportunity for the market and for competition. So I think competition is good, but again, it feels very crowded. We know that traditional treatment options are fraught with serious bleeding risks and incomplete thrombus removal. And so this really necessitated innovation and development of more novel strategies. And while these new interventional approaches really offer potential for improved outcomes with probably fewer serious complications, this rapid development and the need for more comparative clinical evidence is challenging for physicians to really select what is best. I think ultimately, when you're getting into this field, comfort is the most important thing up front, because you of course want to be safe. But once you identify something a good safe option, you want to have something that's durable, obviously, and effective. So we know these new interventional reperfusion treatment modalities use pharmacology that can be mechanical or aspiration. They're designed to essentially reduce bleeding episodes and bleeding risks that are accompanied with the traditional systemic thrombolysis. And of course, get more rapid and more effective thrombus removal up front, which is important. But these new interventional approaches, despite providing optimal patient care, if you will, their rapid development has really outpaced the published guidelines. And so it's very difficult for you to decide what is right and what is wrong. Yeah. And so I think most of us revert back to our comfort level. I mean, I think there's been a shift from lytic-based therapy, primarily due to the risks of bleeding, because it's really, when you're trying to help somebody, the risk of having a intracranial hemorrhage really outweighs any benefit or long-term effect from decreasing chronic thromboembolic pulmonary hypertension. So it's challenging, and I think things will be easier once we have more data, which is forthcoming.
Dr. Noam, that data that Dr. Mawad's talking about, what are you looking for when new devices are coming down that pipeline? What do you want companies to sell you on, and what are the pieces of the puzzle that they need to show?
So one of the important things for me is low profile, because the bigger the tube, yes, you can aspirate or remove more clot, but also lower profile is important because the access site is also important. And the ability to have that device navigate the pulmonary vasculature, especially if you have some sort of, not necessarily in the main pulmonary artery, but just you're going down into the segments. I'm a firm believer that a lot of the hemodynamic changes can be improved with just, some form of revascularization without complete thrombus removal. So I think that's the first step, because patients, when they come in distress, it's either their oxygenation, but it's because you have a roadblock to blood flow. So obtaining that pathway, in my mind, is with any device, even a low-profile device. As long as you're able to debulk some of that thrombus, you're going to improve the hemodynamics. And then my approach has been not a complete cleanup of the thrombus, but open up a pathway, and then long-term anticoagulation. By long-term, I'm saying at least more than 3 months, because we know that there's plenty of data on recanalization over time. So if you're able to remove the clot burden, especially in acute thrombus, and you're able to place them on anticoagulation 6 months to a year, you're going to be able to see some significant recanalization within that time. And sometimes that obviates the risk of a prolonged procedure in certain patients. But again, the more thrombus you remove at the first sitting, the more important or the better the outcomes are, of course. You get the hemodynamic instability improved, you decrease the clot burden, patients do better and so forth. But in terms of devices, I mean, the ability of the device to be malleable and to be low profile up to a certain extent. You know, you're not going to use like a 6-7 French device and try to debulk a 3-centimeter vessel. I mean, that's going to be out of the question. But those are important elements because, you know, there's certainly access complications that we see, or, you know, the device is a little too stiff, and it's causing some trauma to the pulmonary valve. So that's a problem.
Yeah. So I know you probably weren't expecting it, Dr. Haddad, but with the discussion from some seasoned vascular surgeons telling you how they evaluate these devices, when you go into practice, after what you've seen in your training after 5, 6, 7 years, what are you going to do when you get into practice? Are there people, do you know if there are people that are already doing this at the practice you're going to?
So it depends on the hospital they're practicing at. Some of them do have PE capabilities. Some of them do have a team that's, you know, has experience doing these cases. That's really the big thing. And I think that's what Dr. Mawad was mentioning is comfort. And not only is it comfort using a device, but comfort performing these cases in that setting. And if you have a team that's never done it before, you don't have an ICU bed that you can possibly put this patient in. Do you have ECMO capabilities in the, you know, very acute, unstable patient? Some of these hospitals that we'll be working at do have them, some of them don't. And so that's kind of where I gauge it personally.
One of the things we actually missed, I think, a little bit in the journal was talking about the education aspect of this. And so we've got a tiny bit of time that I'd like to actually ask you, know, what is your comfort level going to practice? These are high acuity cases. Sure. They're some of the scariest cases that you can set foot in. And if you're a new guy coming into a hospital, is this something you're going to jump right in? And you know, you'd love to call your senior partner and say, hey, can you join me and help me do this one? But is this something that we are arming our trainees with that you can do coming out? Is this something that you're looking forward to, something you're a little nervous about, a little bit of both?
You know, and after the age of COVID, we saw so many PEs, and even in the periphery when I was in Baytown with Dr. Nurko, and I feel like probably half of our cases for a solid 6 months were doing PE cases. And then coming downtown, a lot of them were PE cases as well. So I know our trainees graduating this year are very comfortable because we are the COVID trainees that came in seeing a huge influx of PEs. Really, there was one device that we really got super comfortable with to start, and that was kind of the only device that really had available at the time. Since then, like you said, multiple devices have come onto the market, and once you've become comfortable with one device and doing these cases, I think that's when you start to become more comfortable branching out and trying new things.
So do you think that's because you have more comfort with the pathology as a whole?
I think so, yes.
Okay.
Yeah.
So then I would open that up to the non-interventionalist. Is this something that we need to be really focusing on from an education standpoint, from the non-interventionalist arm for how we triage these patients, how we work together as a team in this specific instance? What does that look like going forward in terms of our non-interventional friends that are going to be interfacing with us? Like you said, there's a comfort that comes from seeing a lot of this. How are we going to change those training paradigms?
I'll actually take that because I got my involvement in this, as a matter of fact, came from my non-interventional colleagues. I had a very close cardiology partner. We have a multi-specialty group, and he's a pulmonary hypertension specialist. And he's like, hey, look, I'm seeing these patients over and over and over again, and they're suffering, and really need to do something about this. But he's not an interventionalist. And he's like, I think, you know, and he showed me some preliminary data, you know, we were talking like multiple years ago. And he was like, I really think there's an opportunity here because I think, you know, people with retained pulmonary emboli and CTEP and CTED and so forth are very, very difficult for them to manage. And he's like, look, I'll see these patients, they get referred to me with PEs, but I'm not an interventionalist. Would you be interested in getting involved? And that's essentially how I got involved in this practice altogether. I was like, well, yeah, you know what? I mean, I'm used to doing interventions, other parts and around the body. This is going to be a learning curve for me, but we can do it together. And that's essentially what happens. So I think awareness is number one, but I think education is critical, particularly for those that are up and coming. I mean, it really needs to be up there. Like, as you said, standardized stroke care, standardized STEMI care. There really is an opportunity here to manage these patients up front. And of course, we want to avoid the long-term sequelae of CTED and CTEF with those with PE.
So for the non-vascular surgeons on the panel, chime in. How do we engage this on an education and a training standpoint in your disciplines and then at the interface between all of our disciplines?
I think the hardest thing to do, I may be the only non-interventionalist here, so sorry. But the hardest thing for me was honestly helping my interventionalists understand why this is a safe procedure to do. The guidelines didn't really help them or make them feel justified that they could offer the benefit. And, you know, we're seeing different phenotypes of PE. What do you do when you have the 35-year-old woman with breast cancer who needs to continue chemotherapy and her ACOG score drops from 4 to 1? What do you do if you have large embolic burden, but there's no signs of RV strain, but you walk that patient 20 feet and they can't walk, but their troponin and BNP are normal and their echo at baseline is negative? You know, are we going to generate a pulmonary cripple, or should we reduce their vascular burden? And those are complex conversations. And sometimes my interventionalists are like, I don't have a good criteria to go in, but I know I need to go get it. So that collaboration between the interventionalist and non-interventionalist becomes really key. I personally do a 6-minute walk test on all my patients who are borderline with them after they're anticoagulated to see, is there a benefit or a harm? And then do full informed consent to the patients. But I also understand the interventionalist hesitation, and understanding that has really helped me triage in their favor and being really sensitive. So one of the things I was really interested in hearing about, you guys talk about the devices, is the integration of blood preservation, blood loss preservation, I think has been really, really helpful. Because sometimes when we're doing these catheter-directed thrombectomies and we're seeing a lot of blood loss, I wasn't aware of how much blood y'all were losing in the lab. That wasn't being passed off to the bedside critical care team when they were first coming out. So we're like, they're supposed to be an RV failure, but now they're PE's treated. Now they're really hypovolemic. What's going on? We couldn't put it together. And then like 4 hours later, oh, their blood count dropped quite a bit. How much blood did you lose in there? And it's always 50 cc's. And we're like, okay, it's more than that. So I think that's where it's really helpful. And I've, you know, personally as a non-interventionalist, I've learned the most by following in and scrubbing into my interventionalist procedures and really building that relationship with them to know what they're seeing on the table, the physiology with the anesthesiologist, everything. So this is a disease where we have a lot of learning to do. It's not like cabbages or our normal pathways, you know, and even now we're seeing reduction in ICU admissions for PE at our systems with our PERT teams. They're all going to IMUs now. And so now it's my hospitalists, my ER physicians who need to get really comfortable triaging this disease and understanding where we go. So I would say right now we need to be on a string as much as possible until we get more comfort, more training. So my hope is this COVID generation, as Dr. Dodd said, is like really, really familiar and really comfortable with this pathology. So we'll see more confidence going forward.
Yeah.
I think there is a responsibility also on the side of the interventionalist to stay open and communicative with all services in the hospital. I mean, I like to remind people that for mechanical problems, they need to go to someone who may have a mechanical solution, whether we do or we don't. But it is a mechanical problem, and we have tools. Whether or not the tools were built for one purpose or not, they can be co-opted. And so a certain degree of creativity is, I think, appropriate in patient care when there are very few options. And I would say, for example, you know, our PERT team in my particular hospital, as it turns out, is run by the interventional radiology section. But we all have access to the same thrombectomy catheters. I get called maybe once a month now to aspirate right-sided endocarditic lesions because they know we have aspiration catheters. We get asked to do things we've never done before, but we have the tools for these, and so we just have to be careful. We're adjudicating them to the right patient and the right clinical scenario, but it's our responsibility to spread the word that there are tools available. So the field may be crowded, but I don't mind. I'm still getting used to figuring out which tool works better for something else, but I'm willing to try a few, even in the same setting, to achieve an appropriate clinical result. And I think to that end, as Dr. Naum pointed out, you have to go into a situation knowing what the goal is. Is the goal, you know, to make everything beautiful? No. Is the goal to keep the patient alive, to recover an RV? What are we trying to achieve? How is the patient not doing well, and what would we accept as a good result? Because you don't want to take 5 hours experimenting on a patient when you're not exactly sure what it is you're trying to achieve. You need to know it and need to know how to do it.
Not to spoil too much of the Methodist DeBakey education side, one of the things that I really love is the cardiology for the non-cardiologist. as a non-cardiologist, it's shocking sometimes as a vascular surgeon how little I have kept up with a lot of these basic things. And is there a role, you think, Dr. Lumsden, for maybe a PE or VTE care for the non-interventionalists? Since this is so exciting in the interventional realm because things are changing so rapidly, but maybe it is time for us to really engage on that education side within our system and then really put it out there.
Yeah, we actually did do a thing on PE and CTF one year, but we haven't really followed up on it. So you're probably very timely in thinking about it. But let me play devil's advocate for a minute. You've heard the story. I had a patient. They had, submassive PE. I went in with a catheter. We don't even need to go into it. Thought I did a good job. Patient felt better, and then I don't remember the reason that we ended up getting another CAT scan. We ended up with another CAT scan. It looked exactly the same as before we actually did anything, but the patient felt better. And the question was, well, that's a little embarrassing. Do we go back and do it all over again, tell them we didn't achieve anything? And I talked to Tom McGillivray, who was our chief of cardiac surgery, and he said, look, and he's now up in DC as the chair up there. He said, there's immense fibrinolytic capability inside the pulmonary system. Leave it alone. So I left it alone, got another CAT scan about a month later when the patient came back. Normal. Okay, there was nothing left. So, I think it's great we all believe these patients at the high end are probably undertreated. I think one of the things we need data for is to make sure they're not going to get overtreated. As we get this plethora of devices and you got every company and their grandmother beating down the door to tell us we should be treating. That's where you're going to need the data, because I have enough distrust in the cardiovascular specialists as a whole that there's a risk, and I'll make a prediction right now, 4 years from now, we're going to have exactly the opposite conversation about overutilization of this, and defining where the benefit is, I think, is going to be really important. And that's where we need people like you, Pavan, who are going to keep our feet to the fire and make sure it's always appropriate.
All right.
I'd like to make just one comment regarding that. It was interesting. I worked here in the U.S. for some time, and every lower extremity vein thrombosis was, okay, let's go thrombolysis. That's the way to do it. Until I went abroad and I worked abroad, and Craig McNamara catheters were rarely available, hard to get. TPA was very difficult to obtain, and so on. So we didn't have that capability, but we did have the capability. We had rivaroxaban, the Bigatran, and apixaban available probably before we had them available as indication here in the U.S. If you're able to get a patient on full anticoagulation with proper levels, and you did your ultrasounds in clinic, it was incredible the amount of recanalization that we're able to see at 3, 6, 8, 9, and 12 months. So that sort of opened up the idea that, like Dr. Lumsden said, the body has an incredible ability to recanalize on therapeutic anticoagulation, which is usually hard to achieve with warfarin and the Coumadin-like medications. But that is incredible for acute thrombosis. Somebody had symptoms 2, 3 days ago, or a day ago, or today. But sometimes we get these chronic patients who have symptoms for about 2 to 3 weeks, sort of subacute to more chronic. Those are going to be a little bit harder to recanalize. But again, the intrinsic ability of the body to recanalize is incredible, as long as the patient is maintained on uninterrupted anticoagulation.
So I guess that's the question is, in my case, it didn't look like we'd done anything, but we had done something. We were there. We were messing with the thrombus. And so I guess the question, nobody knows the answer to this, how much clot do you have to remove? Or, because there are devices up there like an egg beater, you just kind of whirl them around a little bit and let the intrinsic fibrinolysis work. And so does anyone really have any perspective on what's the mechanism? How much clot do you need to remove versus open up flow? A little bit like the lower extremity. If you don't get flow, things are doomed to failure. But once you start getting flow through it, then, TPA is endogenous. And so you canalize this stuff.
I have to admit, in our practice, we don't have a definitive endpoint for how much clot to get out. we go entirely based on how the heart is functioning. And if we are able to reset different markers of right heart dysfunction, that's good enough for us to stop.
Real time. You're doing this real time.
Real time.
So what are you doing?
Pressure, pulmonary artery pressures is a great way of looking at things. Doesn't always reset that quickly, but heart rate will come down. Oxygenation is, I think, a weaker one. But for us, we rarely even take pictures intra-op because we actually don't care how much blood or blood clot is left over. What we care about is how much is this affecting the heart, because what we're trying to prevent is that catastrophic failure, because we don't want to overtreat these patients. We don't want to go down that line of we're chasing every little bit of clot in the pulmonary arteries. But it's a very important point that this is very easy to yo-yo back and forth between over and under treating. And that segues really nicely into IVC filters, which, there's certain segments of our medical community that see these as the worst thing ever. It depends how much late night television you watch and how many commercials you see for the lawyers these days. But you guys wrote a great article on all these advanced techniques in terms of how to get them out. I've seen some of them myself, done some of them myself. But one of the things that's pretty remarkable is, I've been in this now 12 years. We're no better at finding these patients and making sure that these filters come out of people. Is this a problem? I mean, is this something that we need to, we used to have a part of our phone tree here at Methodist was, 1 for this, 2 for this, 5 is if you've got a filter that needs to come out, right? And, I don't know if it's still there, but this is something, do we need to go after these people? Do we need to find these filters? What are the long-term complications?
So definitely long-term complications. I think the more common ones that we see are going to be the migrations, the perforations over time, the IVC thrombosis that we're all have seen before. But yeah, it is important to find them. It is important to bring them back. And I think the biggest thing, the way to do that is just follow up, communicating with that primary team, communicating with that patient. Our clinic often calls our patients, and the ones that get lost to follow-up are most often, I think, the ICU patients, where we get called for an IVC filter, they can't tolerate anticoagulation, we put a filter in, and then we say, all right, call us when they're better, and then they get better. Who knows, 2-3 months down the road, goes home, and patient has no idea they have an IVC filter.
So I have a question for you. As a trainee here at Houston Methodist, do you know the percentage of filters that come out that you guys put in?
That's a great question.
98%.
That's a great question.
It's a very important question. And I want to talk to our panel about this. Do you know the number?
Sure.
That's the question that always comes up. Is forget whether you think you're doing a good job or a bad job, but do you actually know the number?
No.
So open it up to our team of experts here. Do you guys know? Because you guys see filters in all of your practices. Is there a number you know? Is there a robust system? We don't have standards for this. I see a lot of shaking heads.
So I think it's important to try to keep your own database. Unless you're doing, I don't think anybody's doing hundreds of these. I don't know. But I like to keep a database, Excel sheet, and then you provide it every month. You go over it and give it to your nurse or MA, and they can call the patient, see what's going on with the patient and so forth. And I think that's the best way. Actually, there's an old study in the military that the filters that when they were able to get significant compliance is when they kept the database and they were proactively calling patients. So I started doing that, and that tends to do pretty well. You'll see which patients eventually you can triage them and say, okay, well, yes, we're going to take that filter out, or nope, that filter is not coming out because you're still having issues, etc. And it's not, and we need to keep the filter there. The other thing to remember is that 2 years risk of DVT goes up by having a filter in. So then those who keep a filter in, you bring them back, you screen them for DVTs, and you try to manage them with whatever, either a prophylactic dose of anticoagulation they can tolerate or other maneuvers to prevent that DVT from recurring.
Yeah, but that's
in today. I call the office and tell them to schedule removal. But to that end, they'll call 3 times, as I think Tom said. The ICU patients are the hardest ones to get back. And you lose those. So at the end of the day, I don't have a good clue, but you make an effort as best you can to as soon as you put it in, call your office and have them schedule removal in 60 days, and hopefully you can keep track of them that way.
Yeah. So I should tell a story that Thomas alluded to. I can't remember, this must be 10 years ago. There was all this press about complications from filters. So we thought, okay, we're concerned that we haven't taken them all out. We got permission from our legal team to go through the entire Methodist database for the past 5 to 10 years, identify patients who had filters, and we communicated with them. There were people who were so pissed off that they didn't even know that they had a filter placed. And now we were telling them that they needed an operation for it. And so it was never let a good deed go unpunished, because it didn't work.
No. No, and that it brings up a very good question. I mean, these are labor-intensive processes to keep track of people that have complicated medical conditions in the hospital. And it really, this couldn't have struck me more. About a week ago, I was having a conversation with my mother, who lives in St. Louis currently. And I'm here in Houston. I've never heard a description of a patient with CTEPH over a phone with a non-clinician more obvious than this conversation with my mother, who happened to just be walking with someone else in the park, and they happened to mention that they'd had some sort of blood clot in their lungs. It was so big, and they didn't know to take it out, and they've just been a pulmonary cripple since then, and they'd had another CT scan. They had a lot of clot still there, and I'm listening to my mother telling me this and going, I don't know the first thing about where I should send you, because I'm here, I'm 1,000 miles from you. I don't know what the right location is. I have the diagnosis in my head. So, Dr. Steinberg, how do we find the right people? How do we, this is something that I'm head deep in this space, but I have a hard time going, how do I get the right expertise? How do you look up the right person? Who is that right person? Who is that ideal person? I have in my head that this person that my mother identifies probably going to be someone that needs care from someone like yourself, a team that you have. But how do we identify these people? For if we were talking to all the primary care doctors in our country for identifying patients that got lost in the shuffle coming out of the ICUs and the hospitals, how do we find all of these patients that really should be followed and then identified for potential intervention?
That's a huge question. And I'm not sure I have the answer. I'm the guy that the people who find them end up sending them to. I work with great pulmonary hypertension experts, and all the workup is done by the time they come to me. But I am very much intimately involved, and of course I speak with every patient that comes through a suite, if you will, of BPA procedures. And their stories, there's a lot of similarities. And the story you're giving is sort of a dead ringer for it. And many don't even know they've had a clot. I'd say first and foremost, if you're a clinician and you're not thinking CTEPH, it's going to be really hard to actually nail that diagnosis. Yep. And I'd say probably the way it will most easily come about is when shortness of breath and someone eventually thinks about the heart and away from the lungs and gets an echo and starts seeing RV strain. And then you can go down that pathway. I'd say there's really kind of two different patient archetypes. The ones with the big PEs that have gotten initial care, but then no follow-up, and they never had a full resolution. And those are the patients we absolutely should be following, and it should be standard to get follow-up imaging, whether or not it's an echo to look at RV pressure and RV strain, whether or not it's a follow-up CT just to see whether or not the burden of disease has resolved. Although I will say, if you have small vessel disease, CTs are not the best for picking that up. It's VQ scans, which is not a great screening test overall, just for everyone who necessarily has a PE. So I do think there needs to be some follow-up. We need to be listening to patients and making sure they become symptom-free. And if not, we need to be very aggressive looking for it. But then there's this whole other category of patients who have had smaller PEs that have never resolved, and they get progressively worse. And part of the issue is that they're presenting with slowly progressive dyspnea, which is one of 1,000 things. And it's so non-specific. So, among those, we think of cardiac issues. And so, usually someone's going to get some sort of cardiac workup somewhere along the line, or they get labeled with asthma, and then they get a particularly astute pulmonologist, or who has other pulmonology friends or cardiology friends in the space, and it finally triggers it. I am extremely happy when I get someone to do, say, a BPA whose symptom onset is within 5 years. I'm like, that's fresh for me. So I'm dealing with a lot of patients who've had their disease 15 and 20 years. And the problem with this disease is it's self-perpetuating, and it's time-dependent, and not on the order of days or weeks or even months, but on the order of years. But it takes years sometimes to find it, because the unobstructed vasculature undergoes irreversible changes, and people develop a superimposed pulmonary arteriolar hypertension. And that is just no longer a mechanical problem with a mechanical fix. And so that's really a problem. So, if I were counseling, your mother's friend, I'd say you need to find a pulmonary hypertension center, and then B, you need to find someone who has a mechanical fix. And the pulmonary hypertension centers, as far as I understand, is a pretty tight network group, and it's referral out of state is very common for pulmonary hypertension folks.
It sounds like a really good opportunity for a lot of education from a pathway standpoint. So,
Totally. You got to think about it. It's got to be somewhere in the tree, the diagnostic tree. So, the word needs to get out, and I think with more treatment options, it will. But it's a real problem
for sure.
I think it's worth adding real quick to this conversation. One of the questions that comes up for the PERT teams now that we're starting to see this data with CTEPH and CTEPD is that how much clot you leave into this patient, how harmful is that? We know that patients that are discharged with clot, they have a higher risk of recurrent VTE. About 50%, if they're on therapeutic anticoagulation, like Dr. Noem said, is they will have full resolution of their symptoms. But the other 50%, they progress on.
That's the key group.
And so the question becomes, at that index hospitalization, what is the value when you're in that thrombectomy, and how much are y'all thinking about that potential 10, 15 year, and only 50% of the patients will still have this as you're retrieving clot? I never think about it because I'm not an interventionalist, but as I start to look at this on a spectrum of disease, and we're seeing these patients chronically over time develop it, is that a consideration y'all have when you're doing the thrombectomies?
Well, that's the question we're going to have to let hang in the air until the next edition comes out, because we've hit the bewitching hour, and around here that's 6 o'clock at night. So let me kind of wind it up and say thank you all for participating. Great conversation, very robust conversation, and hope to meet you all in person soon. But thank you all.
Thank you.